Dorothy has updated the location and time of her office hours on the Canvas website. Which location did you pick? It's my lab. So it'll be in my lab on 17 Hill House. And the times, I think, are unchanged for those of you that want. And I have my own office hours. I forgot the time. It's today, I think, like 3:30 to 4:30 or something, but also by appointment. So you're always welcome to come by. Thank you for doing the disease category exercise. I'll use that in tomorrow's class. Are there any questions on the material so far? I always will start with that question every class. So, it's normal and fine to ask questions. Yeah, what's your name?
There's obviously like a lot of...
I'm sorry, what's your name?
Johnny.
John.
Johnny.
Johnny.
Yeah. There's obviously like a lot of information that we're learning about. Is there anything that you want us to like focus on, or like any themes that...
Well, they're the big ideas that animate the course: structure and agency, emergence, collective versus individual. We'll introduce another idea, I can't remember if it's today or next time, on natural and social lottery. But no, I expect you to do the reading, and I covered mostly I touch on all the readings in every lecture, try to connect them, and then I use other materials during it. The readings have been honed over the years to be, some weeks are very light, some weeks are a bit bigger, but on average it's what I would consider to be an appropriate amount of reading for a Yale undergrad. I know it seems like a lot of stuff to take in. I'm trying to make it clear, and no, it's okay, no worries. Yeah. Also, all the slides. In fact, I'm remiss. Dorothy, would you help me remember to send you the PDFs for the slides so we can post them on the class website? I actually forgot to do that this past week. So all the slides will be on the class website, and all the lectures are videotaped and will be released. Yeah.
I was just wondering, to what extent should we kind of internalize the methods used in each of the studies? Because there's lots of creations of formulas to...
No, that's not. I don't. Class is not about statistical inference or methodology. Historically, on the final exam, I have asked students, I've often given a question like design your own experiment kind of question, and then by the end of the course, you will have had a number of illustrative studies about experiments. I guess that would be the only question remotely that might be kind of a methodology, but I'm not going to ask you what's the threat to causal inference in this study, or how did the scientists know for sure this is true, or anything like that. Although we have a lot of ingenious studies. Today, the Diane Lauderdale study today is very ingenious on Arab names, and we'll talk about that. Other questions? Someone else here? No? Everyone's cool? So last time we discussed the ways of measuring socioeconomic status and the variation in life expectancy according to SES. We looked at ways that health and SES could be causally interrelated, with SES causing health and health causing SES. And we reviewed possible mechanisms for both directions, including such things as risk behaviors and access to health care and reduced earnings due to illness and so on. And we considered the fact that this directionality of the relationship could vary across the life course. It's not like one or the other. And even if it's both, it could change according to when in the life course we're talking about. And we examined some new ideas about how SES might affect health, including ideas about relative position in social hierarchy, which we'll come back to, and there's some cool things we're going to talk about that. The issue of in utero exposures, which we'll also return to later on, and this problem of genetic confounding. Like some other genetic factor might cause both health and SES. And so, we need to take that into account when we think about this topic, which we'll also return to later in the class. And we close with some remarks about the idea of fundamental causes in the social sciences, which is a very important idea. And also something we'll return to again, as we build ideas and knowledge about the concepts that we are considering. Now, I'd like to start today to an idea we introduced towards the end of the last class, having to do with the notion of a natural and social lottery. And here's an excerpt from a letter that Thomas Jefferson sent to John Adams. He said, this was in 1813. By the way, they both died on, I think, July 4th. And they were political opponents, but they were personal friends. They were there at the Revolution, and they had this incredible correspondence that went on for decades. Here's one letter that Jefferson sends to Adams. For I agree with you that there is a natural aristocracy among men. Of course, he meant men and women. The grounds of this are virtue and talents. Formerly, bodily powers gave place among the aristi. Aristi is like the aristocracy, those at the top. But since the invention of gunpowder has armed the weak as well as the strong with missile death, bodily strength, like beauty, good humor, politeness, and other accomplishments, has become but an auxiliary ground of distinction. There is also an artificial aristocracy founded on wealth and birth, without either virtue or talents. The natural aristocracy I consider as the most precious gift of nature for the instruction, the trusts, and the government of society. And indeed, it would have been inconsistent in creation to have formed man for the social state and not to have provided virtue and wisdom enough to manage the concerns of the society. May we not even say that that form of government is the best which provides the most effectually for a pure selection of these natural aristi into the offices of government. The artificial aristocracy is a mischievous ingredient in government, and provision should be made to prevent its ascendancy. Do you understand what he's saying, despite the kind of old-fashioned language? He's saying that if you're born to wealth and power, if your wealth and power are socially ascribed, that's awful. We don't want you in government. But if you are, by born to, he means that are socially assigned. But if you're naturally endowed with talents, you're a moral person, you're a smart person, then that would be great. And anyone from any walk of life should have access to the levers of government as a result of that. Now let me restate this idea. Imagine we are setting out to create a just society, similar to the argument in Rawls' famous theory of justice. Who's read or heard about Rawls' theory of justice? Raise your hands high. About 10% of you maybe. Okay, I'll explain it. Now, at least a couple of immediately obvious causes of difference and potential injustice that we would have to consider are the following. There is the natural lottery that assigns people the natural assets with which they are born. And there's the social lottery that assigns people their social position at birth. The natural lottery assigns people these natural assets with which they are born, and it can affect their life chances, such as how long they live or their intelligence or all kinds of other things. And the social lottery is a way in which one's initial position, family, social class, and so on, affects one's opportunities. It affects how people of similar talents and abilities, as specified by the natural lottery, perform. So two otherwise similar people with similar natural talents, born into different sort of sectors of society, fare differently. And Jefferson says this is unfair and bad for society. To be clear, both lotteries affect people's life chances. Now, here's the subtle argument. Because the amount of resources in any system is finite, more advantaged groups will always command more resources than less advantaged groups, or even exploit the other groups. And if indeed some inequality is intrinsically biological, and it is, some inequality, like I was not born a fast runner or a talented musician or musician at all. Whenever I look at musicians, they're like magicians to me. Like I don't understand how they can do that. Okay? So there's inequality that's assigned because of people's genetic, biological endowments. If some inequality is intrinsically biological, if there is any natural lottery at all, it can be reinforced by the existence of complex social systems that necessarily involve hierarchy operating under a budget constraint. In other words, if there's a finite amount of resources, there's a budget constraint, and some people are just naturally have more ability than others, then the resources in the society will be unequally distributed as a result of that, through the combined operation of the natural lottery plus the kind of workings of a social system. So we might quite rightly wish to constrain or countermand the operation of the social lottery in the name of justice. We might think it's unjust If if there's an arbitrary rule that only people of a certain height can go into the foreign service, we might say, to be diplomats, we might say, wait a minute, height has nothing to do with your ability as a diplomat. We will not allow that. Okay? We don't want that kind of a rule operating in our society. And in fact, we might even want to provide for a social counterbalance to the natural lottery as well. For example, if you're born blind, it's not your fault. And we might say, okay, well, that's the natural lottery operating. Because of that, you might have less access to the finite amount of resources in society. But we, in our civilized society, say, no, we are going to redress that. We are going to give you or help you in some fashion to redress the workings of the natural lottery through the operations of a kind of social process or a social lottery. Interestingly, Jefferson had given thought to this as well, identifying at least one way to deal with the social lottery. And here's what he wrote, again to Adams in 1813. At the first session of our legislature after the Declaration of Independence, we had passed a law abolishing entails. And this was followed by one abolishing the privilege of primogeniture and dividing the lands of intestates equally among all their children or other representatives. These laws, drawn by myself, isn't that incredible? These laws, drawn by myself, laid the axe to the root of pseudo-aristocracy, and had another which I prepared been adopted by the legislature, our work would have been complete. What did Jefferson want to do that he didn't do that would have helped in his view? It was a bill for the more general diffusion of learning. This proposed to divide every county into wards of 5 or 6 miles square, like your townships, he's writing to Adams, in New England. To establish in each ward a free school for reading, writing, and common arithmetic. To provide for the annual selection of the best subjects from these schools who might receive at the public expense a higher degree of education at a district school, and from these district schools to select a certain number of the most promising subjects to be completed at a university where all the useful sciences should be taught. Worth and genius would thus have been sought out from every condition of life and completely prepared by education for defeating the competition of wealth and birth for public trusts. Now I'm going to leave aside the slavery issue with Jefferson, which is obvious, and just take him at face value here in terms of the philosophy that he's advocating. And this man's intellect was amazing. You have to understand how radical this proposal was. This is a threat, right, to the aristocracy. He's saying a free education for everyone based on their abilities and their talents. And in fact, this was a way to compensate for the social lottery, to undo the workings of the aristocracy. And we can compensate for the natural lottery by intervening in it or with the social lottery. Now, when we observe worse health in minority groups, for example, surely most, if not all of this, is due to the social lottery, right? If we look around and we see ethno-racial variation in health outcomes in our society, it's really not the biological, it's not the natural lottery that's causing that. It's the social lottery that's causing that. And this clearly would seem and should seem unjust. But we also have to be mindful of the distinction between unequal outcomes versus unequal treatment. So if we see an ethnic or racial difference, what does it mean? And do we care? Well, if we see a difference between ethnic or racial groups, for instance, in COVID-19 mortality or in vaccination rates, according to the Institute of Medicine, before we judge this to be problematic, we need to do the following. We say, okay, well, we see a difference between two different groups defined along ethno-racial lines. Before we say, okay, that's a problem, a moral problem, a policy problem, a political problem, we got to do a couple things, they say. First of all, we have to adjust for other attributes. We've got to take into account other things like the socioeconomic status. I'll explain this in a moment. The insurance status of the two groups, whether they have comorbid conditions. If we see worse outcomes in blacks with heart attacks than whites with heart attacks, maybe 20% of the whites have diabetes and 80% of the blacks have diabetes. So maybe it's not the heart attacks, that's maybe not race that's causing the difference in heart attack outcomes. Maybe it's the prevalence of diabetes that's causing the difference. So maybe we need to take, I'll come to this, we need to take that into account. Or we need to look at differences in disease severity or stage. So if we see, for example, that Hispanics with lung cancer fare worse than whites with lung cancer, Maybe the Hispanics, when they present to the doctor with their problem, maybe they're at a more advanced stage of illness that's less curable. So the operation of the ethno-racial factor is earlier in the course of illness. It's not that the doctors are discriminating, let's say, against Hispanic patients with lung cancer. It's that when the patients arrive, they're already sicker. Furthermore, if we're going to say something about ethno-racial differences in our society with respect to health or healthcare, we also have to look at some other methodologic features. For example, what kind of data is it based on? Is it using good clinical data? Is the data collected prospectively in a forward, like starting now, looking forward, which tends to be a stronger design than looking backward? Is there an objective standard for appropriateness? I'll come back to that. Like, can we say this is truly better than that, rather than, well, whites have more of it, so it must be better? And finally, we need to account for patient preferences. We need to make sure that whatever we observe as a difference isn't because people themselves are choosing different kinds of care, and that's relevant to our understanding. So whether you think that some or all of these are important also depends in part on your conceptual model of how race and ethnicity might work in this situation. Now, there's abundant evidence that once you control for socioeconomic status and other factors like comorbid illness or occupation, ethno-racial differences in health status substantially decline or even disappear. So like if you go out and you account for the fact that on average minorities are poorer than non-minorities, if you account for that poverty, then you say, oh, there's no difference between the racial minority and the majority population. But see, that's not the end of the conversation, or even the end of our understanding of the problem. Because the problem is, what does this mean? And it depends on your perspective about what you think is going on, about how you think ethnicity or race might be working. And this can happen in at least two different ways. So one possibility is that there's something about being in a racial group that has some impact on your health. And independent of that, there's something about being in some educational category that has an effect on your health. In this type of a situation, if you're trying to make a statement about whether race affects health, you would want to adjust for education to make sure that your estimate of the effect of race upon health wasn't because of differences in educational status in the two groups. If this was your model, your conceptual model for the true state of the world, a completely different model of the true state of the world is this model, that race affects educational outcomes and educational outcomes affect health. If this is the true state of the world, if you come into this data set and adjust for education, you might find, oh, there's no effect of race on health. But would that actually be true? It would not be true, because the way race affects health is by affecting education. So once you adjust for education, you have wrongly concluded that race has no effect. Okay? You've falsely come to the conclusion, oh, race has nothing to do with this because I've adjusted for education. But the point was that the way race was affecting health was by affecting education. Now, the tricky part is, in both of these situations, in this situation, you would want to adjust for education if this is the true state of the world. And in this situation, you would not want to. But you can't necessarily know in advance what is actually going on. So in the top, both independently affect health. And if we want to get a pure estimate of the effect of race, it makes sense to control for education. And if we control for education and the race effect disappears, that's okay. It means race has no independent effect on health after you control for education. But in the bottom, race leads to a poor education. And so controlling for it effaces the effect in a potentially misleading way. Here, race is still causal, that is to say, it's causally prior to and causing ill health, but we've made it disappear for the wrong reason. In the bottom, race is on the causal path between education and health. Or what if someone tells you, comes to you, here's an example, someone tells you, after taking into account the quality of the ingredients, the expertise of the chef, the ambience of the restaurant, we find that a meal at McDonald's offers nearly the same experience at a meal as a super fancy restaurant. After we take into account all of those factors, there's no difference between a McDonald's and a swanky restaurant. And you say, wait a minute, that's the whole point. The swanky restaurant McDonald's has all those awful features. Once you take that into account, then you say the McDonald's is the same as a fancy restaurant. You've done the wrong thing, right? Because those things are on the path. It's the McDonald's causes these, things like what did I list there? Bad ingredients, bad ambience, and so on, and that's what causes the food eating experience at the end. So in both cases shown here, controlling for education will typically reduce the impact of race in this situation. And what does this mean then about the causal status of race? Well, these have policy implications. In the bottom, and by the way, what I'm about to tell you helps clarify this point even more, because I can see that half of you are still with me and half of you are like, I'm not quite sure I get what he's saying yet. So here's another way of thinking about it. In the bottom, giving everyone a free and good education will solve the problem of race. Whereas in the top, race still might have its own effect. Do you understand? So let's say you don't know which of these is the true state of the world. And you now miraculously give everyone a great education. In this situation, you would still find an effect of race on health. But in this situation, you would not. Do you understand? So this difference in models, another way you can tell the difference is by thinking about, well, what would I have to do to make this go away? And if I did it and it went away, what would I conclude? Sophia? Lucy, I keep misnaming you. I'm sorry. Yeah, Lucy.
Okay. I'm curious about what happens if you try to draw an arrow in the top model between race and education as well.
Yeah, in fact, the real state of affairs is combined, yes. And in fact, health can go back to education. The real state of the world is vastly more complicated than this, right? There's an arrow that goes both ways here, and there's an arrow that goes from race to education. We don't think education affects race or health affects race, so you understand, yeah.
Yeah, I guess my more pointed question, other than can we do this, is at what point does the analysis become so complex that it's just not useful anymore?
Well, I wouldn't say it's not useful, and I'm going to comment on that in a moment because this is a difficult topic to discuss. In fact, I think maybe it's even the next slide, so I'll come to that. So I don't want to overdo the correspondence, but in the top, race is part of the natural lottery, and in the bottom, it's part of the social lottery, right? In the bottom, you are getting your education arises because you didn't pick your race, you were assigned it at birth, and then now you get an educate. The social world works and assigns educational opportunities disparately according to race, and then that affects your health. That's a social lottery. Whereas at the top, I don't want to overdo the correspondence, but that's a little bit what this is. And so here's a similar example. Imagine that we're looking at weight, and it's absolutely the case that men are heavier than women on average, and we know that taller people are heavier than shorter people. So here, sex and height independently affect weight. But if it was the case that the reason men weigh more than women was simply because they were taller, then we would want to, if we controlled for height, and we found a 5'7" man and a 5'7" woman, and we just looked at men and women of the same height, do you think men and women of the same height would weigh the same or not? You would still think that men weighed more than women at the same height. And so if you're trying to estimate the effect of sex on weight, you would imagine that this is the actual model, not this model. Okay? And controlling for height would efface the effect of sex on weight wrongly in this type of a situation. Now, before proceeding, and this gets back to Lucy's question, I need to say that it can be hard to talk about race and ethnicity. And on the one hand, it absolutely shouldn't matter. And I always struggle with whether to teach this in this class, this topic, because talking about race and ethnicity reifies it and privileges it and reinforces its importance. And there are quite a few good reasons not to discuss race and ethnicity. First of all, it overstates the role of ethnicity and race as reflecting genetic or biological differences between population groups, which are actually very few. It fails to reflect the fluid and dynamic nature of sociopolitical identity for many people, right? People identify in different ways on their own. It fails to reflect the way many Americans choose to define themselves. And it furthermore contributes to divisions in our society if we keep talking about this, as much as we do. On the other hand, it does seem to matter when it comes to health. So not talking about it can also appear irresponsible, right? I can hardly teach you a course on the social determinants of health and not discuss the role of race and ethnicity in healthcare and health outcomes, because there are many, and we'll talk about them. So let's look at this a little bit. This slide shows the effects of adjustment for the level of education on the disparity in potential life years lost between black persons and white persons according to the specific cause of death. So for example, if you just go to the data and you look at what's the racial disparity in potential life years lost, you find that, for example, after adjusting for age and sex, you find that, for example, black people have a higher, so this is black versus white difference. You find that there's more life years lost to blacks than whites of the same age and sex from cardiovascular disease. So here's the line of no difference. There's no difference between blacks and whites in terms of the burden of this disease. After you control for education, it declines, but there's still a black-white difference. You see, these are the point estimates in the 95% confidence intervals, and this does not include 0. So this is statistically different than 0. Okay, so it means after controlling for age, sex, and education, it's still the case that blacks have a higher burden of cardiovascular disease than whites. What about cancer? Well, at the beginning, before you control for education, blacks have worse cancer than life years lost than whites. But once you control for education, there's no difference. What about infection? Well, education moves it down. Always education tends to move it down in most of these situations. And for many things like lung disease, there's no black-white difference to begin with. They both are, there's no difference, whether you control for education or not. Same for renal disease, liver disease, and so on. But you can kind of see the fact that, first of all, adjusting for education attenuates the black-white difference. And second, it depends by condition. But whether you think this solves the issue of race still depends on your causal model, right? This alone doesn't tell you what's going on. In other words, if this is what's happening, race causes education, causes health, and you say, well, there's this big black-white difference in cardiovascular, well, let's pick cancer. There's a big black-white difference in cancer, but once we control for education, there isn't any more, so we don't need to worry about black-white differences in cancer care in our society. Right? Say, well, once we control for education, it's just that, blacks tend to be less educated than whites, and once we control for education, there's no difference anymore. So really there's no race operation of racism in our healthcare system because there's no difference. Does everyone understand what I'm saying? But that would be fine if this was what was actually going on. But if this is what's going on, race causes people to have worse education, and it's the worse education that causes the ill health, then making this adjustment is exactly the wrong thing to do. Because it falsely leads you to conclude, oh, don't worry, when in fact you should be very worried because of the operation of race in modifying the ability of people to have equal access, let's say, to a good education. So let's get a handle on some of the black-white differences in the use of medical procedures. Here's some data based on the review of a large sample of patients' administrative records. And so these are procedures per 1,000 people. And this is the number of procedures in blacks versus whites. And then here's the black-white ratio. So we find that blacks get 2.5 angioplasties. Angioplasties are a procedure where you thread a needle into a person's groin. It goes up, actually, their arterial system, and then into the aorta, and then out through the coronary arteries. And the little balloon is threaded into the coronary arteries on the surface of the heart, and then it's expanded to open up blockages in the arteries on the surface of the heart that provide blood supply to the heart. So blacks get 2.5, whites get 5.4. So blacks get about half as many as whites. Coronary bypass surgery, similar picture. Mammography, similar picture. Hip fracture repair, similar picture. Limb amputation, blacks get many more limbs amputated than whites. Bilateral orchiectomy, that's removal of both testicles, blacks get many more. There's no way you can look at this pattern of data and not be saying, oh, what is going on here? And these differences may reflect complex mixes of disease prevalence. So limb amputations, for example, are often done for diabetes. Diabetes is more common in blacks than whites. Maybe that's the reason that there's so many more limb amputations. And bilateral orchiectomy is an old-fashioned treatment for prostate cancer. Prostate cancer is more common in blacks than whites. Maybe that's the reason. Or maybe it's not the whole reason. You don't know. Just looking at the difference alone is not enough to come to a conclusion as to what's going on. Because, as I said, these differences may reflect complex mixes of disease prevalence, patient preferences, and the workings of the healthcare system, or not. Certainly, many African Americans have perceived a difference in access to care, and whites also do so, albeit to a lesser extent. This slide shows data regarding an answer to the following question. Americans were asked, do you think the average African American is better off, worse off, or just about as well off as the average white person in terms of access to health care? Okay? So whites are asked this question, and about 10% say blacks are better off in terms of access to health care, and 50% say about the same, and then whatever the next thing is, worse off is 30%. And African Americans have a different perspective. They think about the same. 10% think that blacks are better off in terms of access to health care. Who knows why some people might give this answer? Does anyone know? There's like a really subtle and interesting reason. Yeah.
Is it that there's been like the Christakis, the experiments, and
No, the Tuskegee experiments were an awful case in which the opposite was the case, where black people were selected for worse care. They were denied access to antibiotics when they were known to have syphilis. These are blacks and whites. About 10% think that blacks have better access to care. What could be a possible reason for this? Does anyone know? This is very subtle. You probably wouldn't know. Has anyone ever noticed where are elite teaching hospitals located in our society? In black communities. Now, why was that originally? What? It was for racist reasons, right? That's why they were put there. So that doctors could be trained on poor minority people, right? But in the 100 years since then, where's Johns Hopkins? Where's Harvard Medical School hospitals? Where are all these elite hospitals? They're in black communities, okay? And often, so some of these people are probably saying this, oh my God, I can get my health care at Johns Hopkins. That's where I get my health care. I get it at the Harvard teaching hospitals where I get my health care, okay? Not necessarily for the right reasons, okay? A historical artifact, but that may explain part of this, okay? So complicated. The story's not always simple. And of course, understandably, the majority of African Americans think that they're worse off with respect to the health care that they get in our society. But just because there are differences doesn't necessarily mean they're problematic. There are several sources of difference, only some of which we might regard as, bad, as problematic. For example, there might be patient-level factors. These are potential sources of disparities in healthcare. Patient-level factors like patient preferences or refusal of treatment or poor adherence or some few biological differences between different ethno-racial groups. Or there could be health systems level factors having to do with financing or the structure of care or cultural or linguistic barriers that might explain it. Or there could be doctor level factors, disparities that arise from the clinical encounter, doctors that treat patients of different ethno-racial groups differently. And we saw the last time, for example, with the Back to Sleep campaign, that sometimes low SES can be associated with poor adherence or a patient-level choice in some sense, right? So that was a free campaign that was rolled out to everybody, and yet people with lower SES didn't follow the advice. So then if we find a minority, non-minority difference in outcomes in the babies, that's not necessarily because valuable information was being withheld from some group or something. Do you understand? Maybe it was, I don't want to put my baby on their back. I was taught by my grandma that baby needs to be on his face when he goes to sleep. And I don't believe these people. All right? So it looks like this. This is the kind of way to think about it. This is taken from a classic paper by Gomez and Maguire from 2001. Here, if we look at the quality of healthcare, some measure of healthcare, and we look at a non-minority group, and they have some level of quality here, and a minority group, and they have this lower level of quality, and there's a difference. And there almost always is a difference, okay? That's an empirical fact about the world. But now the question is, what might explain the difference. And there are three possible things I mentioned: clinical appropriateness and need, and patient preferences. Maybe we have more limb amputations in blacks and whites because they actually need more. Okay, they have more diabetes, and people with diabetes, often their extremities need to be amputated because the blood flow stops to their extremity and the extremity is dying. Okay, or maybe there are ethno-racial, as I'll show you, and as was in your readings, ethno-racial differences in patient preferences. Okay, we wouldn't think that was necessarily there was a difference, but not a disparity. But there are other subcategories which we would deem to be a disparity. For example, in operation of the healthcare system and the legal and regulatory climate, maybe there are things that are systematic that are causing this difference, that are unjust. Or maybe there's provider discrimination, that the doctors and the nurses and healthcare providers are acting in a fashion that's invidious, with prejudice and bias towards different groups. And within that, there are three categories, which I'll talk to you about. There's bias, stereotyping, and uncertainty. Three different sources of the ways in which doctors and nurses might treat patients differently. Now, it's also worth noting that sometimes whites receive more services, perhaps even for bad reasons, but they wind up being harmed by this and are decidedly not better off as a result. This is not to excuse any prejudice, but just to say that it may be a good thing in some studies to have an objective standard of appropriateness rather than merely looking at black-white differences. We'll have done minorities no favors if we roll out to them ineffective or dangerous forms of medical care that are being given to majority groups. So that's a final thing that's not on this list, right? Maybe the minority groups are getting less of something, but actually it's great that they're getting less of that thing, okay? Because the majority group is getting more of this thing, maybe for wrong reasons, but they're being harmed by whatever it is that we're giving them. Well, let's look at the idea that, is this clear so far? Let's look at the idea that minorities' preferences regarding care might play a part in this difference. And this is a study from your readings in which 800 subjects older than 65 who self-identified in various ethnic and racial groups were surveyed about their preferences with respect to various aspects of medical care. And this slide shows the percentage of African American, European American, Korean American, and Mexican Americans who think that physicians should inform the patient that they have cancer, which is the diagnosis, and that they will probably die, which is the prognosis. Now, I took care of patients of all of these ethno-racial categories for decades, not decades, a decade and a half before I stopped seeing patients. And these sort of findings were very much my clinical experience. Blacks, whites, Hispanics, and Koreans had different, when you went to the bedside and you said, you talk to the family, grandma's dying, I'd like to go in and talk to grandma about her dying, which is what we were taught to do. The family, no, you can't do that, right? Some of you, I'm sure, will have that sense, or will know that from your background, that's normative where you are. So, for example, this is the percent of subjects that thought that physicians should inform patients about serious diagnosis. So here is diagnosis amongst African Americans. But look, if in Korean Americans, 50% of Korean Americans thought that the doctor shouldn't tell the patient what the serious diagnosis was. That's the way they are. That's the way they want. Same with prognosis. So there's relatively little difference between African Americans and European Americans in this situation, and here Mexican Americans somewhere in between. So if we go into a hospital and we ask patients, did your doctor talk to you about your diagnosis? And we find that, the doctors talk to the patients about diagnosis if the patient was white, but not if they were Korean. We say, oh my God, that's horribly racist of the doctors. Not necessarily. Maybe the patients didn't want to be told that. You're not necessarily doing the patient a favor by forcing them, I'm here to tell you the awful bad news, even though you don't want to hear it. Just now listen to me, right? So if you're going to be a good doctor, you need to have some kind of sensitivity to where the patient is coming from. But it can be very difficult because maybe it doesn't feel right to you to withhold information, right? It's another whole topic we'll come back to when we talk about the care of the dying in a few lectures. Now, the same reading showed that there were ethnic variation regarding beliefs about whether the decision to put a patient on life support machine should be made by the patient, family, physician, or someone else. In fact, in my clinical experience, and this has also been shown by multiple studies, African Americans tend to be more high-tech avid than white Americans. In other words, if you have a patient who's seriously ill and you go talk to the family and you say, well, we think, grandma is going to die, but we could admit them to the ICU, and then they would suffer, and then this is not how you would actually do it, so please understand I'm simplifying this so that you can get the point. But they would first suffer, and then they would die. Black families would say, yes, we absolutely want ICU care, whereas white families say, no, never mind, doc. Okay? So, there are differences in, and they don't always come out the way you think, right? Sometimes minority populations are more avid for whatever healthcare is on offer. Sometimes they're less avid. For example, with hospice care, I was a hospice doctor. Oftentimes, minority populations of different kinds of minorities would be less interested in hospice care. So if we found a difference in levels of hospice care, and when we come back to the end of life class, we'll do that. We'll talk about that. Difference in the amount of hospice care offered to different ethno-racial groups. Maybe it just reflects patient preferences, in which case that's great. That's what people want. They should get it in our rich democracy. And in fact, African Americans often have an increased taste for ICU care, as I just said, and a decreased taste for hospice care or COVID vaccines. So there was a black-white difference in COVID vaccines. What if, in fact, you sit down with a patient and you talk to them about the risks and benefits such as they are of a COVID vaccine, and on average, the black patient doesn't want it as much as a white patient? Well, then what? Are you going to force them, give them the shot even though they don't want it? And if you don't, and then you observe a difference, well, maybe that's okay. So long as you've actually fairly rolled it out and offered it to everyone, which is crucial. And that's always part of the rub, is figuring out what's going on when we find a difference. And in fact, there could also be discrimination by providers, which, as I mentioned earlier, can be divided into 3 types. So if you're a doctor and you are caring for a patient, you could discriminate in the care you offer to patients based on any attribute, including ethnicity and race, for at least 3 different reasons. One is bias, which is a prejudicial way of treating minority groups with lower regard than non-minorities by virtue of holding negative views. That's clearly bad and wrong and should be eliminated. The second is stereotyping. Stereotyping is a cognitive heuristic or judgment based on group membership without necessary negative intent. For example, minorities are less likely to comply with treatment. That could be an empirical truth. Or Korean Americans are less likely to want to be told the diagnosis. That's an empirical truth, right? It may not apply to you, in this case, to an individual patient. It's a stereotype, okay? Do you understand? Or minorities prefer expensive invasive treatment, which is true, right? So if we see more expensive treatment being offered to minority groups, it doesn't mean that we're preferentially treating them. It may be what they want. It's a stereotype. And last, and subtly, and I'll come back to it in a moment, is uncertainty. That is to say, it may be the case that there's greater difficulty in interpreting symptoms in one group compared to another. So in this situation, the doctor is confused. And I'll show you a picture of this, which will make the point clear. Stereotypes, according to social psychologists, refer to the process by which people use social categories in acquiring, processing, and recalling information about others. And in practice, it can be very difficult to distinguish this from bias. Well, let's flesh these 3 ideas out a bit more. These are histograms, basically they're histograms of illness severity for 2 groups with cut points indicating when the doctor would treat the patient at a fixed level of severity, and in this case resulting in the treatment of more whites. So, for example, you might imagine, okay, let's look at what is the severity of some condition, like heart disease severity, and we find that, here's the bell-shaped distribution of the severity for blacks. Okay, here's the black severity density. And here's the white severity density. Okay? And now a benevolent doctor has a fixed threshold. It says if your symptoms are above this line here, if you have chest pain and jaw numbness, no matter whether you're black or white, bang, you get treated for a heart attack. Okay? That would be a benevolent doctor. And we might then notice that more whites are treated than blacks, but not because of any discriminatory practice by the doctors. Do you understand? The underlying severity density, okay, so let's say black patients present with a different symptom profile than white patients. The doctor is acting in this fixed fashion, and then you find a difference. This would be a benevolent action. It wouldn't necessarily reflect some kind of operation of bias. Here, more whites are treated than blacks, but there's no bias. A biased doctor assigns treatment to blacks at a lower rate than whites or at a higher severity level given the same severity distribution. So now imagine that blacks and whites have the same severity distribution, but the doctor says, well, if you're white, I'll give you the treatment at this level. You have to have more symptoms before I treat you if you're black. That's clearly wrong. That's clearly biased. Do you understand? Because the blacks and whites do not differ in their underlying manifestations of the illness, and yet the doctor is preferentially setting a higher threshold before they treat the blacks, okay, in this population. Is everyone with me still? A confused or uncertain doctor makes mistakes, but he or she does not mean to. For example, if the symptoms in minorities are a less reliable indicator of the existence or severity of disease, there could be what the authors of this paper call miscommunication between patients and doctors will assign treatment to minorities with error. And this is also known as the problem of uncertainty, and it can contribute to discrimination. In this situation, there's more dispersion in blacks, let's say, in their symptoms, given a particular disease, with a flatter distribution and more people at the top and the bottom, even with the same mean. So in this situation, here's the black signal density. Okay, so you're looking now at how many, given you have heart attacks, how many blacks with a heart attack have minor symptoms, more and more typical symptoms, more and more severe symptoms, and how many whites do. And here's the distribution for whites. It's a histogram. The average is the same. The average black patient and the average white patient has similar symptoms when they have a heart attack, but the distribution is flatter for blacks than for whites. So there are more people with minor symptoms and more people with major symptoms in the minority population. Okay? So if that's the truth, and given this increasing amount of uncertainty, the doctor may set a higher threshold for treatment if symptoms in a minority patient are less likely to be indicative of disease. And this higher threshold may be warranted in this reason in order to capture the same fraction of patients. So in other words, if you integrate under the curve, if you set the threshold for black patients here, and you look at the area under the curve, if you remember high school calculus, okay, got the sense here? You guys don't have to like shiver and like panic about it. Okay, but you remember like you learned the area under the curve. If you colored this area under the curve here, you would get, I don't know, I'm making up a number, 15% of the black patients would be treated, but you'd have to set the line here for whites to get the same 15%. So in this situation, yes, doctors require a higher cut point to treat blacks than whites, but they're getting the same upper end of the distribution. Do you understand? So merely observing that the doctors have a higher cut point in blacks than whites, like 2 or 3 slides ago. Remember we said this was unjust? We said this was wrong, we said. And it was wrong. So if you go into and you see doctors, boy, the doctors require that black patients be really sick before they get treated, and they treat any old white patient, which is awful, if this is the truth. But if this is the truth, then maybe it's not awful. Do you understand? So it's hard. This is, you can see I'm giving you a lot of information about this topic because it's not easy. Emily, right? Yes.
2 questions. First, why should it be the goal that we want to treat 50%?
Oh, that's so subtle. I don't know if I want to answer that. It might not be the goal. Exactly right, which is another complication. Because you're right, we might want to set the same threshold regardless. Part of the problem is that if we set the same threshold, we might be over-treating people who don't need treatment. So in other words, some minority people who you know, we're now setting the same threshold and we're treating many more of them, and they actually didn't need treatment because the intrinsic nature of the disease in them is different. So you have to have a higher cut point. But you could also be right. It's possible. Do you understand what I said? Yeah.
And what if, like, what we see as a typical symptom is based on white people?
Also excellent. Fantastic. If in fact, this is another point, need more complexity. If we, remember when I said a few lectures ago about how body temperature was normed by this German guy who measured a bunch of Germans and 150 years ago, and that's how he got 98.6? If we go to the world and we say, well, what counts as a symptom for heart attacks? And we just look at 1,000 white dudes. And then we find these are what the symptoms are. And we say, aha, That's the gold standard. Then we apply it, we've done the wrong thing again, right? That's exactly right. So you have to then have, and this is where it gets really hard, because I don't want to imagine that they're like ethno-racially specific treatment algorithms in our healthcare system. It's hard, right? I want to imagine that we're all human beings, and you have chest pain and it radiates down your arm, and you have tachycardia, and that means you're having a heart attack, and it doesn't matter whether you're black or white. By the way, on that point, women have been undertreated for heart attacks for a very long time, because the symptoms of heart attacks in women are different than the symptoms in men. But the standards for what counts as serious heart attack was based on men. Even when I'm 61, when I went to medical school, we were taught these were the symptoms, and all these women would have heart attacks. They have an occult heart attack. Under our noses, they had a heart attack, and it's very mysterious. Well, because we weren't taught, like actually that in women they could be having a heart attack, and it doesn't present the same way that it does in guys, right? But these are additional levels of complexity that you've just pointed on the table. You're right about both points. I forgot your name.
Sophia.
Oh, you're Sophia, and she's Lucy. Okay, I'm going to get this.
Just out of curiosity, how does it present in women?
So women often have more GI symptoms. They present with like some more dyspepsia and stuff, but it's been a long time since I've been in a hospital taking care of people with heart. I have done it. I took care of seriously of people with heart attacks, but it's been a while. Yeah. But they tend to have less of that classic chest pain. And we were taught that I forgot what it's called. There's a famous people with heart attacks often literally come in. I've seen this dozens of times. They make this symbol. They say, "Oh, doc, I have chest pain," and they literally hold up their hand like this, make a fist, because it feels like they'll say, "I feel like an elephant is sitting on my chest." These are classic statements, more men than women, I think. Yes, I forgot your name.
Carol.
Carol.
So I was trying to understand the graphs a bit more. So are the differences in the shapes of the curves and the density just due to biological?
Yes, it could be biological or life history or something else. We didn't even discuss that, but it could be the case. Right now we're simplifying things by saying black-white as if that's some kind of, it's a portmanteau. I mean, it could be men and women could be different. It could be old and young. It could be many different things, immigrant and non-immigrant, and all of those could play a role in different ways in yielding this. So it's absolutely the case that if you divide a population into two, the differences, and then you plot some kind of curves, the differences wouldn't necessarily just be differences in mean. They could also be differences in dispersion, right? There's no reason why one group couldn't have a wider variance than another group. That could also be true. So don't assume that just because you divide, if I divide you guys into, this is a stupid example, but let's say I divide the men and women in this room, and then I measure your running speed. The men on average are going to be faster than the women, but there could be another thing. There could be more variance in the men than the women, for example, right? It's not required that the variance be the same in the two groups. And when the variance is different, it can give rise to further problems and complications in understanding what's going on. Did I answer your question, Carol?
Yeah, and I was also just wondering, have these density curves been determined are these theoretical? Or?
These are theoretical in this paper. For some conditions, they have been. And there's a politically very fraught one, which I'm not going to discuss today, but maybe some other time or during office hours we can discuss that. This comes up.
Because I was thinking if there's anything that may arise in affecting how these density curves are determined in the first place.
Yes, there is some work on how this arises, and partly it's biological, and partly can be social exposures as well. So there are lots of ways it can arise. For now, we don't need to know how the variance might change. We can just know that it can be different, and that therefore it can lead to these kinds of inferential problems we've been discussing. Remind me your name? Rena.
Yes.
Rena, Carol, Sophia, Lucy.
Is it Kara?
I think Kara.
Kara.
Yeah.
Kara. Thank you, Kara. Yes.
Yeah, my question was that I'm wondering how we can reconcile population level, we could look at this. And I know that one of our readings was talking about surveying all these studies of implicit bias. It was a factor of smaller effect with people having individual experiences and writing about them. I'm thinking Serena Williams, for example.
Yeah, so this is another whole thing which I didn't mention a moment ago. In the end, we're human beings, each of us individuals. You should be treated as an individual person. You come into the hospital, you should get the care that you need and deserve. And I shouldn't be relying on bias, stereotype, or anything else, right? That's exactly right. So we're talking about population. Of course, in public health, we're talking about population level differences, and there are population level differences. The question is, where do they come from? What should we do about it? And today you're learning a little bit about where they come from, and you're learning, I hope, that it's complicated, right? It's not like a simple story. It's complicated. And and in case you haven't noticed, everything I've told you so far, all of these play a role, okay? It's not like one or the other. They're all there. Discrimination, bias, prejudice, patient preference differences, operations of the healthcare system, different causal models for what's going on. It's complicated. So I can summarize some of the work that McGuire and his colleagues have done in this area as follows. And once again, I need to see if I'm running out of time because, I'm so interested in talking to you guys that I just... So he says that there's limited evidence for bias, but patients certainly do report the experience of discrimination. Evidence suggests that physicians do use these cognitive shortcuts. Okay, so for example, if you have a black patient that comes in to a pediatric emergency room that says they have real sudden extreme pain in their extremities, you can think, well, the fact that they're black might affect the probability that they have sickle cell disease. That's a kind of stereotype. It's not wrong, but let's do the test and make sure that they actually do and not just assume. Or uncertainty. Evidence suggests that doctors do use race in a probabilistic way to make diagnoses and implement treatments in a kind of statistical discrimination. And all of this, it's hard to accept these things, isn't it? And as I have here in my notes, individuals are not groups. And ultimately, we have to treat individuals. I'm just going to keep going for a second. But of course, no doubt, there is discrimination in our society and in our healthcare system, and it can harm people's health outcomes. This is a very clever study from your readings done by epidemiologist Diane Lauderdale, and she studied a sample of all babies born in California in the 6 months after 9/11 compared to the same 6 months the year before. And she computed the ratio of the risk of low birth weight in the two periods in each ethnic group. And she found no change in any of the other groups except Arab Americans. This is a very ingenious study, okay? So what she did is she looked at the relative risk of being small in different ethno-racial groups according to comparing the risk of being small after 9/11 and a year earlier in the same 6-month period. And so there's no excess risk measured in all women or in foreign-born women or non-Hispanic whites or any of these other groups until you get to Arabic-named women. And suddenly, after 9/11, Arabic-named women are much more likely, 34% higher relative risk, of having a low birth weight baby after 9/11 than a year earlier. Okay? Well, maybe it's some weird, crazy stars aligned and that's what happened. Or maybe something was happening to these women in our society while they were pregnant after 9/11. And then she said, well, she got further ingenious, Diane did. I know her, she's a terrific scientist. She said, well, if this is the case, maybe if we divide the infants according to whether they had a really ethnically distinctive name that really signals that they're Arabic or Muslim, or not so ethnically distinctive, we might theorize that women who give their babies particularly Arab-sounding names might visibly seem more Arab, maybe more likely to wear hijab or something like that, which might, in our society, have further increased their risk of being discriminated against or otherwise feel treated in a prejudicial way. And lo and behold, she finds such an effect, okay? That there seems to be grading of the effect, which is further evidence in the likely causal nature of what we are observing in this situation. And a follow-up study showed that this effect wasn't limited to Muslims. Physical appearance can serve as a marker for discrimination, including cultural practices that are perceived as Islamic, such as wearing head coverings, or physical traits such as skin color. And this design built on the Lauderdale study to identify additional subgroups of mothers using name-matching methods, including mothers with ancestry from Arab and non-Arab countries in the Middle East and North Africa, and non-Muslim majority South Asian countries, and a subset of South Asian Sikh mothers. And this slide shows risk ratios and 95% confidence intervals for the post-9/11 change in risk of low birth weight for each of these groups. And they find that not only were the Middle Eastern and North African sort of Arab Muslim women worse off, but the Sikhs, who aren't Arab or Muslim, they just wear turbans, and the average American doesn't know the difference, and they also experienced an impact after 9/11, further supporting the subtle ideas that were being advanced about the role of discrimination in our society in the Lauderdale study. Well, how might we explore whether doctors themselves discriminate, whether due to bias or stereotyping or uncertainty? So here's a study. You could just ask people, do you discriminate against minority patients? But they would say, no, I don't discriminate. Or you say, do you discriminate against gay patients? Or do you discriminate against substance users, IV drug users? And they would say, no, I do not. So how can you tell if people are acting in a discriminatory fashion, given that they don't necessarily want to reveal it? Well, you can do an experiment. These are photos that accompanied an experiment involving 720 physicians who watched a video of an actor describing some chest pain symptoms. But different actors were shown with the same story. So there were 4 different videos made. Always the actor tells the same story, but sometimes you had a woman actor or a male actor, and sometimes you had an older actor or a younger actor. Story is always the same, but you just have a different appearing person. Background is the same. You get the otoscope and the blood pressure cuff in the very typical medical background. The needle disposal thing, and the little nightie, the gown that's ridiculous. And they tell their story about their chest pain. And the physicians were asked to do a bunch of things when they were shown these videos. One was to estimate the likelihood that the patient actually had coronary artery disease. So given that you see this, do you think this patient describing these symptoms, do you think they may have had coronary artery disease? Which goes back to some of the questions Kara, I think, and others were asking earlier. And then, after they were asked, do you think the person has coronary artery disease, then they were asked, would you recommend a procedure for this person? Okay? And which is a catheterization procedure, which threads the little catheter into the bloodstream and measures whether there's blockage in the coronary arteries, which can be risky and may or may not be appropriate. And the study found that the physician's estimates of the probability of coronary artery disease before the results of a stress test were given them differed according to sex and age and history of the patients. But the patterns of the differences were consistent with the known prevalence of coronary artery disease in various groups of patients. So for example, a younger patient describing that they have chest pain, I might say, well, there's a 60% chance they have coronary artery disease. But the same description in an older patient, I might say there's an 80% chance. That's rational, right? The older people are more likely to have coronary artery disease. There's nothing necessarily wrong with that. But then, crucially, the doctors were told a test result that confirmed the presence of coronary artery disease. And then they were asked, would you order a catheterization or not? Okay? So now the doctors are saying, well, what do you think? Is it likely that this patient has coronary artery disease or not? They give their estimates, and now you say, I'm going to tell you the truth now, because I've done this test. Here, they do or they do not. Now, would you order this, the treatment for this, would you order the catheterization, given that you've been told that they do in fact have coronary artery disease? And here are the 4 analogous black actors. So there were 8 different conditions, young and old, male and female, black and white. And here are the key results. Did the doctors refer the patients for cardiac catheterization? And they found that men were more likely to be referred than women, and whites were more likely to be referred than blacks by these doctors. This is a pretty good study showing discrimination by doctors. Not a ton, but it's here. Okay? Now let's turn to another interesting set of findings, and cumulatively at a population level, this could add up. So let's turn to another interesting set of findings from your readings, and these investigators looked at healthcare of millions of patients spread out over 79 broad geographic regions in the United States. And they found that differences in healthcare are driven more by residence than by race. More generally, average disparities are driven by the fact that blacks tend to live disproportionately in regions of low overall rates for both blacks and whites. So equalizing rates within regions would not reduce disparities nationally. Moreover, these investigators also found that a region with small racial disparities in one procedure is just as likely to have a high disparity in other procedures, which subverts the idea that there's some kind of systematic prejudice by doctors. If we thought the doctors were discriminating against blacks versus whites, we should find that they did it in every region. The blacks got less than the whites on every procedure. But that's not what they found. They found that in this region, blacks got less than whites in this procedure, but everything else was okay. And over here, it was a different procedure. Furthermore, as shown on this slide, regarding a simple and important test in diabetics, this test for hemoglobin A1C, regions with the smallest racial disparities are not necessarily the ones providing the best available care for black patients. So let's look at this. This shows black-white differences in a test for hemoglobin A1C. It's a test for diabetes in diabetics. So if you're diabetic, you should get this test. That's standard of care. It's a good thing. You should get it. In 79 different regions of the United States, hospital referral regions. And this shows the percentage of blacks that receive the test, and this shows the percentage of whites receiving the test on the x-axis. And if there's no disparity, you would go along this diagonal line. So if the fraction of blacks getting it is the same as the fraction of whites, you would be along the diagonal. And what you find is that in general, this is where this is the number of regions where blacks tend to have more, and only in 2 of them, or 3 of them, only in 3 of the 79 regions do black people in that region get more of this necessary test than white people. And in every other one, whites get more than blacks, which is bad. Okay? Probably not for a good reason. But now let's have a look and see. If you look, for example, at Washington, D.C., which is on the far right over there, there's a big disparity between blacks and whites in Washington, D.C., a disparity of 14%. But blacks are still better off than if they lived in Chicago, which has a smaller disparity. So, for example, here, 60% of blacks in Washington get the test, compared to 45% of blacks in Chicago. There's a lower disparity in Chicago, and there's a higher disparity in Washington. But if we equalize the disparity here among blacks and move this point up to the line, we still haven't done as well for them as if they had been in Washington, D.C. And this reflects the fact that blacks and whites live in different parts of the country in our society. There's more dispersion along the line than up and down. That is, there's more variation in disparities between regions than within regions. And finally, the conclusion in this study, which you read, is that large racial disparities in surgery are often the result of high white rates rather than low black rates when judged by external standards of appropriateness. So once again, the story is complicated. And to make it even more complicated, I would be remiss if I did not alert you to still another problem or complication, which is that there's something known as the Hispanic paradox. And this came up last week when we talked about the SIDS back to sleep example. Because of the composition by socioeconomic traits, the health and mortality profile in Hispanics is expected to resemble that of African Americans more closely than that of non-Hispanic whites. But it does not. It's a paradox in that the expectation is not consistent with observation. So in fact, what you find is if you look at years of life expectancy by age, the people that do the best are foreign-born Hispanics. And then here you have foreign-born Mexicans and non-Hispanic whites. So both Hispanic groups outperform survival of whites in our society. And in fact, there's a Hispanic paradox in most health metrics: birth weight, infant mortality, adult mortality, late adult health. The Hispanic population in our society is healthier than the white population. And in fact, there are 2 hypotheses regarding the origins of the Hispanic paradox. One is the so-called healthy migrant effect, which is that Hispanic migrants are selected from origin populations for certain traits, including better physical and psychological health. Maybe the only Hispanic subpopulations that make it to our society within 1 or 2 generations, or the current generation, are fitter, are healthier to begin with, and that's why we observe it. Another possibility is the salmon bias effect, which is that migrants from some Hispanic subgroups may return to their country of origin following a period of temporary unemployment or illness. So here the idea is that if you're like an older Mexican who loses their job or becomes unhealthy, you go home to Mexico to die or to be cared for by your family, and therefore are removed from the numerator in our society. So our statistics look falsely like Hispanics have better health, but it's simply because of the salmon, returning home effect. Now, I don't unfortunately have enough time. I was going to explain to you exactly how the implicit association test works. You probably all heard about the implicit bias test. It was invented at Yale by a social psychologist by the name of Mazar Banaji, who's a friend of mine. It relies on the fact that given certain stimuli, you might more rapidly associate the stimulus with certain words than with other words. And the rapidity with which you make the association is taken to reflect some kind of implicit bias that you might have. I don't have the time to walk you through the details of how it works, but if you want to just go to this URL, you can actually take it yourself and you'll figure it out very quickly, like how it works. And when people do this test, so a typical IAT procedure involves a series of tasks. And in the first task, an individual is asked to categorize stimuli into two categories. For example, a person might be presented with a computer screen in which the word black appears in the top left corner and the word white appears in the top right-hand corner. And in the middle of the screen is a word, and the respondent is asked to sort the word into the appropriate category by pressing the appropriate left or right-hand key. And then the next task, they would be given a similar sorting procedure with photos of black and white people. And then there's another task which tries to confound them. And after you do all this, you can come to some conclusion about whether people have some kind of implicit associations of different, actually it's not just races, it could be anything, old and young people or whatever. And it turns out that everyone has biases. And the work by psychologist Mazar Banaji and her colleagues suggests the widespread presence of such unconscious bias, at least when the bias is measured this way. And there's a big debate right now whether this is actually measuring bias or not. I'm going to skirt that. I'm just going to assume it's clearly measuring something. There's no doubt about that. Whether it's actually bias, it's another topic. And these are results regarding implicit and explicit attitudes towards race measured in the form of effect sizes known as Cohen's d, separately for white and black respondents. On the explicit measures, on the right, white respondents showed a preference for white over black, and black respondents showed an opposite and even stronger preference for black over white. So this is a percentage. This on this axis is the preference for whites over blacks. And now we look at the explicit and we ask whites, well, do you prefer whites? And they say yes to this extent. And we ask blacks, do you prefer blacks? And say yes to this extent, somewhat greater extent. And now we look at the implicit preferences, and both groups prefer white. Whites more than blacks, but even blacks say that, using this implicit association test, there's more of an association of white with certain good words in this implicit bias measure. Anyway, if you go to the website and you take the test, you'll see how it works. It's ingenious and interesting. Many studies since the introduction of the implicit association test, however, have shown that while many or most people, black or white or every human being, have biases, every human being has biases, that's just a fact, they often or even usually do not act on them. For obvious reasons, studies have focused on physicians too. And this was in your readings, and they looked at a systematic review of these studies, and they found 9 studies that involved physicians measured bias using the IAT and assessed their clinical practice with vignettes or record reviews. So you guys are all doctors, black, white, men, women. I give you the test. I measure how much bias you have. You'll all have it. I guarantee it. And then now I go look at the care you've delivered, and they found that your implicit bias, such as it was not associated with black-white differences in the care you delivered. All 9 studies confirmed the presence of IAT measured bias at the upper end of the slight bias range, favoring white patients, though pediatricians had lower levels of bias. My brother's a pediatrician. He loved this. But 7 of the studies found no correlation between IAT bias and physician practice, which is telling. 2 studies found a possible but not conclusive evidence of effects on practice in terms of clinical decision-making. Now, many prior studies have been unable to make a link between explicit bias and physician behavior. But if conscious bias doesn't have an effect, how could unconscious bias have one? In other words, if you find that doctors are not actually discriminating against patients, and then you want to say, well, but they still have an unconscious bias, if you find that doctors who actually say, I prefer whites to blacks, still don't treat them differently, it's really hard to then believe that people with just the implicit preference would have an effect on their care, if even those with the explicit preference do not. Moreover, recent work has shown that training people about their biases doesn't appear to change their bias, and in some cases may even worsen beliefs and practices by raising the salience of factors such as race that previously did not loom large in their minds. So you can imagine doctors that are just taking care of patients and they really aren't paying much attention to the patient's race. Now you come in, you administer this test, and all of a sudden they're like, oh my God, I should be thinking about the patient's race. You might find that actually that makes things worse. Let me be very clear. Human beings, black, white, or anything, manifest in-group bias, a preference for their own group. And this is sad and often perturbing, and it can lead to all kinds of evil if extreme. But we should focus